Hello, my name is Simon Marsh and I'm one of the consultants here at 108 Harley Street. Founded in 1991 by the late Jerry Gilmore, 108 Harley Street is a fully independent multidisciplinary practice with consultants in a variety of specialties, and you can see the clinics we run across the bottom of the slides. So I'm part of the London Breast Clinic team, but I also lead the Gilmore Groin and Hernia Clinic, and I work with my colleagues in the Skin Clinic and in the Sports Injury Clinic as well. Now, we're aware that obviously times are changing and the way that we interact with our fellow professionals is also changing. As part of our continuing commitment to medical education and to help maintain effective communication not only with our GP colleagues, but also with physiotherapists and other allied health professionals, we're embarking on a variety of short presentations that reflect the services that we offer here at 108 Harley Street, including but not limited to breast problems, hernias, Gilmore's groin, vascular surgery, dermatology, gynaecology, and so on. And we're going to deliver these as a series of live lunchtime events, but we'll also make them available on the website so people can view them at their leisure. And our aim in these short talks is to cover one topic in around 12 slides, about 20 minutes. And we're going to try and make these 108 Harley Street CPD snippets easily digestible, not too onerous, and maybe even a little entertaining. Now, if you have suggestions for topics you'd like us to cover in future, you can see the email address at the bottom of the slide, symposiums@108harleystreet.co.uk. So get in touch and we'll try and cover any topics that you think would be helpful. Within each presentation, there's going to be one or two key slides, and you can see the key motif in the top left-hand corner of this slide. So these are the real learning points to look out for from each talk and things to take away.
It rises to about 15 to 20% in the elderly population. Apart from causing significant morbidity to people, it's also important from a coronary and cerebrovascular point of view, because up to 40 to 60% of patients with peripheral vascular disease will have coexisting coronary and cerebrovascular circulation problems as well. And it's also important because a significant proportion of these patients within 5 years will succumb to either cardiovascular events. So it's important to know about peripheral vascular disease and to manage them appropriately. So I think the best way to start off would be to define what peripheral vascular disease is. And I define this as a stenotic or occlusive disease of major arteries that leads to a reduction in blood supply to the affected musculature, reduced oxygen to the muscles which are using them, and hence they cause symptoms and problems. I thought it would be best to sort of divide peripheral vascular disease into the acute presentation, which is time dependent. We define acute as within 14 days of the index event. So if patients present acutely, this is usually a consequence of embolism where clots have formed elsewhere in the body. Say, for instance, as a consequence of atrial fibrillation, they formed a large clot within their ventricle and have shot off little emboli, which can present acutely. It could also be a consequence of a significant MI leading to mural thrombus forming within the ventricle and the clot propagating elsewhere. It could be a consequence of vegetations or proximal aneurysms. Equally, patients who've had previous grafts or previous vascular surgery can clot off these grafts and present with acute limb ischemia. Popliteal aneurysms is another entity which sometimes presents acutely. Patients can present with an acutely ischemic limb that requires urgent intervention. It could also be an acute on chronic presentation where patients have pre-existing atherosclerotic disease within the arteries, and then on top of that, either because of a plaque rupture or because of a distal emboli from the heart, say for instance, they block off their vessels completely and present with acute leg ischemia. My talk today is mostly centered around chronic peripheral vascular disease. We all know about atherosclerosis, claudication, and critical limb ischemia. I'm going to touch upon these topics in a bit more detail today. I'm sure you all know this already. Claudication is derived from the Latin word claudicare, which literally means to limp. And what happens is you get a reliable reproduction of the symptoms on exercise. Patients typically describe cramping pain, which is relieved by rest. Critical limb ischemia, which nowadays people talk about as chronic limb-threatening ischemia. I define this as rest pain of more than 2 weeks duration that does not resolve despite opiate medications or tissue loss. And this is usually associated with a significant reduction in blood pressure. So if you were to measure ankle pressures in these patients, they would be under 50 millimeters of mercury, or the toe pressures, which would be less than 10. So how do these patients present? We know about pain, we know about where it usually occurs. We know that usually patients will present with calf claudication, but it's not completely uncommon for patients to present with thigh problems or buttock issues. And we find that the disease affects downstream to where the arterial disease is. Say, for instance, if they've got disease affecting the superficial femoral artery, patients will present with cramping pain in the calf. And if it's the iliac territory that's involved, it could be the buttocks or the thigh region. Equally, for these patients, it's important to get an appropriate past medical history, because we know there is a significant overlap in patients with diabetes and chronic kidney disease, conditions that can cause calcinosis of the media or the medial layer of the arteries. We know that there is a significant preponderance of peripheral vascular disease in patients who smoke, hence why a smoking history is relevant. And medications, antiplatelets and statins are things that we would normally like these patients to be started on. So if you've got that beforehand, it's brilliant. I'm going to just briefly talk about examination. You are familiar with examining patients with peripheral vascular problems. So it's the capillary filling time, which is usually delayed, palpable or impalpable peripheral pulses, so the pedal pulses, the popliteal pulse and the femoral pulse, whether they've got ulcers, and especially some of these patients can present with interdigital ulcers, so it's important to sort of examine their feet and to sort of look at where these ulcers are. Some of them can have neuroischemic ulcers, so it's important again to look at sensory loss and sensation assessment in patients with foot problems or peripheral vascular disease. How do we manage peripheral vascular disease? This is centered around lifestyle modification and best medical management. So asking patients to give up smoking, best medical management in terms of their antiplatelets, in terms of statins, and controlling their blood pressures. This is particularly relevant if I take you back to my first slide when I talked about concomitant cerebrovascular and coronary circulation disease, and the idea is that we prevent events, cardiovascular events and cerebrovascular events. NICE talks about supervised exercise, and it actually recommends that these patients should be prescribed 2 hours of supervised exercise every week for a period of up to about 3 months. But we know the problems with supervised exercise. Most areas within this country are not covered by supervised exercise programs, and the areas that are patients are incredibly lucky to have those programs available to them. Supervised exercise has been proven to work in these patients, and the idea is that with the chronicity of the disease, the body has been allowed to form collateral channels with walking more, when you ask patients to walk more. And what I typically say to my patients is, when they come to me, is that you're experiencing pain at a certain distance, you walk up to that point, and then you push yourself for that little bit more, so another few steps at that point. And usually they'll come back 6 months later or a year down the line and tell me that, you know, their symptoms are better. We know that the natural history of the disease is such that a significant proportion of these patients will not require any intervention as long as they do all the things that we've talked about. So smoking prevention, smoking cessation, and starting them on their appropriate best medical therapy. There's a new class of drugs, natriurefuryl oxalate, for instance, which is a peripheral vasodilator. This is the only medication that's been approved in our country by NICE for treatment of peripheral vascular disease, and this is recommended for patients who do not respond to supervised exercise, but yet are not candidates for intervention. And lastly, we come down to the intervention stage, which could be with angioplasty and stenting in the first instance, or maybe even bypass surgery. So we know that from a vascular point of view, what I normally say to my patients is we will do investigations, we'll diagnose, we'll work out what's the status of your disease, and then we can talk about intervention. It could be a combination of the two procedures as well. This slide talks about some unusual vascular causes of exercise-induced leg pain, and in particular, this is important because this class of patients present at a different age to the other standard, well-recognized population. So things like popliteal artery entrapment syndrome, which is essentially an anatomical abnormality where the popliteal artery is trapped around the gastrocnemius muscle. And this can present in young adults with exercise-induced pain. And again, this is something that may require surgical correction. Cystic adventitial disease. This is a rare cause of exercise-induced leg pain. And what happens is you get cystic degeneration of the medial layer of the popliteal artery in particular, but it could be elsewhere. There's not that many cases reported. My last, I wrote a paper on cystic adventitial disease, and at that time, there were only about 250 odd cases that have been reported worldwide, so it's quite rare. Large vessel vasculitis. Sometimes patients can present with vasculitis, especially things like Wegener's granulomatosis, where the large vessels are involved, and these patients can present with leg symptoms very similar to peripheral vascular disease, but they would have other stigmata of vasculitis. The sciatic artery is an artery in the fetal circulation. It's a continuation of the internal iliac artery into the leg. And in some patients, you can have a persistence of this sciatic artery. And what happens as a consequence is the external iliac artery and the superficial femoral artery become hyperplastic. And the two arteries in conjunction are unable to supply enough blood into the calf musculature. So these patients can present in early life with claudication type symptoms. Also fibromuscular dysplasia. This is another sort of one of those unusual causes where patients can present with symptoms similar to claudication. So who should you refer? I think anybody with acute ischemia should be referred fairly urgently. If you've got critical limb ischemia, so I refer you back to my definition where patients have got rest pain, ischemic rest pain that we define as pain across the foot. And especially when patients will come to me, they will tell me that they have pain overnight. And it's usually a consequence of both the blood having to work against gravity and also because nocturnal blood pressures tend to be a little bit lower. So patients will come to me and tell me that they have pain across the foot, across the toes. And that's the typical history that I'm looking for. If they've got ulcers, they've got new ulcers, or they've got slow to heal ulcers or painful ulcers, those patients should be referred fairly urgently. If their claudication is lifestyle limiting, now again, these patients, I would normally counsel them. I know you guys are experts at this, but if they need sort of further reinforcement or they need further assessment in terms of sort of educating them about changes that they need to make, walking, exercise, trying to walk through the pain, and also patients when they've got unusual or unexplained symptoms. These are the ones that I suggest that we should refer on to specialists. I've got the email address there on the slide to make any referrals that you may have. Thank you. That's the end of my talk. If you have any questions, there was an email address right at the beginning of my presentation where you can email questions if you have any. Thank you.